The topic is amyloidosis. This topic includes definition, composition of amyloid, pathogenesis of amyloidosis, classification of amyloidosis, staining characteristics of amyloid, amyloidosis of spleen, amyloidosis of kidneys. Definition. Amyloidosis is the term used for a group of diseases characterized by extracellular deposition of fibrillar insoluble proteinaceous substance called amyloid having common morphological appearance, staining properties, and physical structure, but with variable protein composition. Composition of amyloid. Amyloid is composed of two main types of complex proteins. One, fibril proteins, which constitute 95% of the proteins in amyloid. Two, non-fibrillar components, which predominantly include P component, which is a glycoprotein. Fibril proteins can be categorized as 1. AL, that is amyloid light chain protein. 2. AA, amyloid associated protein. Pathogenesis of amyloidosis. Amyloidogenesis or fibrillogenesis is multifactorial. Different mechanisms are involved in various types of amyloid. Deposition of AL amyloid. The stimulus for production of AL amyloid is some disorder of immunoglobulin synthesis. Example, multiple myeloma. Excessive immunoglobulin production is in the form of monoclonal gammopathy, which takes place by monoclonal proliferation of plasma cells, B lymphocytes, or their precursors. Partial degradation occurs in macrophages that are anatomically closely associated with AL amyloid. Non-fibrillar components like AP and GAGs play a role in folding and aggregation of fibril proteins. Deposition of AA amyloid. AA amyloid is directly related to SAA levels, a high density lipoprotein. SAA is synthesized by the liver in response to cytokines released from activated macrophages. The levels of SAA are elevated in long-standing tissue destruction. Example, in chronic inflammation, malignancies, etc. However, SAA levels in isolation do not always lead to AA amyloid. Partial degradation in the form of limited proteolysis takes place in reticuloendothelial cells. Another glycoprotein, amyloid enhancing factor or AEF, plays a significant role. AEF is elaborated in chronic inflammation, cancer, and familial Mediterranean fever. AEF acts as a nidus and accelerates AA amyloid deposition. AP component and glycosaminoglycans play a role in the fibril protein aggregation and its protection from disaggregation again. Classification of amyloidosis. Amyloidosis is broadly classified into systemic or generalized and localized amyloidosis. Systemic or generalized amyloidosis again classified into primary amyloidosis and secondary amyloidosis. Localized amyloidosis is again classified into senile cardiac and senile cerebral amyloidosis. Primary amyloidosis consists of AL fibril proteins. 70% of cases do not have any other associated diseases and thus are cases of true primary amyloidosis. 30% have plasma cell dyscrasias, commonly multiple myeloma. Primary amyloidosis is more common in developed countries, seen in heart, kidney, bowel, skin, peripheral nerves, skeletal muscle, tongue, etc. It's rapidly progressive with poor prognosis. Secondary amyloidosis consists of AA amyloid, occurs typically as a complication of A. Chronic infections like tuberculosis, leprosy, chronic osteomyelitis, chronic pyelonephritis. B. Non-infectious chronic inflammatory conditions like rheumatoid arthritis, inflammatory bowel disease. C. Tumors like renal cell carcinoma, Hodgkin's disease. Secondary amyloidosis is typically distributed in solid abdominal viscera like kidney, liver, spleen, and adrenals. Seen less frequently in developed countries due to containment of infections before they become chronic. Thus, it's more common in underdeveloped and developing countries of the world. Only form of amyloid which occurs in children. Outlook is better if the underlying cause is kept under control. Staining characteristics of amyloid. Stains include hematoxylin and eosin stain, which give a pink, hyaline, homogeneous appearance. Methyl violet and crystal violet, which produce metachromasia, giving rose pink appearance. Congo red stain will be discussed later. Fluorescent stains. Thioflavin T, thioflavin S gives yellow color under ultraviolet light, Congo red stain. All types of amyloid have affinity for Congo red stain. Thus, this method is confirmatory for all amyloid types. Under light microscopy, amyloid stains pink red. When viewed in polarized light, the amyloid characteristically shows apple green birefringence. Diagnosis. The confirmatory methods of tissue diagnosis are the following: biopsy or fine needle aspiration, followed by Congo red staining and examination under polarizing microscopy. Amyloidosis of the spleen. This is a diagram of the cut surface of normal spleen, spleen, and lardaceous spleen. Spleen, gross. Splenic enlargement is not marked. Cut surface shows characteristic translucent, pale and waxy nodules resembling sago grains. Microscopy. Amyloid deposits are seen in the white pulp. Lardaceous spleen, gross appearance, shows moderate to marked splenomegaly. Cut surface shows map-like areas of amyloid. Lard-like means like fat of pigs. Microscopy, amyloid deposits are seen in the red pulp. Amyloidosis of kidneys. It is the most common and the most serious because of ill effects on renal function. The deposits in the kidneys are found in most cases of secondary amyloidosis and in about 1/3 cases of primary amyloidosis. Amyloidosis of the kidney accounts for about 20% of deaths from amyloidosis. Even small quantities of amyloid deposits in the glomeruli can cause proteinuria and nephrotic syndrome. Gross appearance. Kidneys may be normal sized, enlarged, or terminally contracted due to ischemic effect of narrowing of the vascular lumina. Cut surface will be pale, waxy, and translucent. Microscopy. Amyloid deposition occurs primarily in the glomeruli and may also involve peritubular interstitial tissue and the walls of arterioles. In the glomeruli, the deposits initially appear on the basement membrane of the glomerular capillaries, but later extend to produce luminal narrowing and distortion of the glomerular capillary tuft. This results in abnormal increase in permeability of the glomerular capillaries to macromolecules with consequent proteinuria and nephrotic syndrome. In the tubules, the amyloid deposits likewise begin close to tubular epithelial basement membrane. Subsequently, the deposits may extend further outwards into the intertubular connective tissue and inwards to produce degenerative changes in the tubular epithelial cells and amyloid casts in the tubular lumina. Vascular involvement affects chiefly the walls of small arterioles and venules, producing narrowing of the lumina and consequent ischemic effects. Thus, we have seen that amyloid deposition causes morphologic and functional disturbance of the affected organ. Confirmation of amyloid in tissue is done by special stains, most commonly Congo red staining, pink red color, followed by its examination under polarizing microscope, apple green birefringence. Primary amyloidosis is rapidly progressive with poor prognosis. Secondary form can occur at any age, including children, and has better outlook by control of underlying chronic infection or autoimmune disease. Thank you.